Hi everyone, my name is Salman Khan. I'm an SHO and I will be taking you through the pelvic and lower limb x-ray session today for the Radiology Crash Course 101. So the way that I'm going to be structuring this session won't be so much to kind of show you loads of different x-rays to show you all the different possibilities of things you might expect to see, but more to give you a framework to approach these x-rays, to give you a system that will hopefully allow you to pick out the most important features of an x-ray that you'll encounter either in your exams or on the wards in practice, on your on-call shifts and so on. Now, this system is pretty straightforward. I call it the ABS system, and effectively what you'll be looking at will be these three. So A stands for the alignment. Now, what I mean by that will be firstly the alignment of the image itself. So the image, this means that the quality of the radiograph has the correct orientation that will allow you to see the features that you need to. But also this refers to the joints as well. So this will be things such as, firstly, whether the correct bones are articulating where we would expect them to in their respective joints, or also whether the joint spaces are correct themselves, because obviously that can change in the context of things such as osteoarthritis and so on. Furthermore, when we're talking about alignment, the concept of using orthogonal views will be quite important, i.e. having x-rays of the same body part but from a different angle, because sometimes when you're looking at a 2D image from one aspect, it might hide issues with the alignment of the bones that you'll be needing to look at from another angle. Fine. Now the next part will be bones, and again, this is another fairly straightforward area. The main thing that we'll be looking at here will be the bony borders, firstly, of all the bones that are in the x-rays that you're looking at. And the things that we want to be considering will be, are they smooth, like we would expect? Is there any evidence of any arthritic changes, such as in osteoarthritis, or any areas of lucency, which can be suggestive of other diseases, such as in myeloma, where lytic lesions are sometimes visible on the plain film radiographs. They can also be suggestive of smaller fractures, which don't have obvious fracture lines visible in the bone on the plain film. The last bit that we have here is the soft tissue component. So the first thing that will be quite important in this will be to look at the swellings that you'll see. Okay, so swellings, you should be able to see these, and specifically for the pelvic and lower limb x-rays, quite often you will be using these to assess joint pains or pains in the bones, especially following trauma, and hence the soft tissue swellings can be very helpful in directing where you might expect to see the pathology that you're looking at. Beyond that, other things that you'll encounter will be things such as fat pads, and sometimes you might see areas of bleeding. And to some extent, what you can also put into this bracket, although it's not quite soft tissue, it's more just an other, will be things such as joint prosthesis or prostheses. Fine. So moving on to our first x-rays. So these will be the pelvic x-rays. And the approach that I want you to take, so we're going to again follow the ABS approach. So the first thing will be the alignment, and what we'll be looking at firstly to assess the quality of the image alignment will be to look at the spinous processes over here and to check that they line up with the sacrum and the pubic symphysis, which in this radiograph we do have. Following that, we want to check that all of the joints are aligned where we would expect them. So we can see the sacroiliac joints over here, and we can see the femoral heads and the acetabulums communicating correctly as we would expect them to over here. And then with the pubic symphysis, we would expect it in an adult above the age of 20 for this to be a distance of no more than 6 millimeters, and in an adult of 50 or above it would be no more than 3 millimeters. This can be different in the context of pubic symphysis diastasis, which we will cover later on. Next we want to move on to B. So this is the bony borders to start with, and in the pelvis we have a few different rings. The first one to look at will be the pelvic inlet, and what this should form should be a smooth ring like we have here. Any breaks to this smooth line might suggest a fracture or a joint dislocation. Beyond that, we have the two obturator rings over here. And then once you've done that, follow the borders of the pelvis, the iliac crests, through the acetabulum, the inferior pubic ramus, again, the acetabulum, the iliac crest, and back over the sacrum. Then we want to follow both femurs, tracing over each of its borders. So we've got the head, the neck, the lesser trochanter, moving through to the diaphysis or the shaft, greater trochanter and back over the neck, and then the head over there. An important line to mention at this point is Shenton's line. Shenton's line exists over here, so it's the line that follows quite nicely from the femur through to the inferior border of the superior pubic ramus. What we should see, like we do in a normal pelvic x-ray, is like this, a very smooth line. So if I write that, Shenton's line. Any changes to this line, for instance, if we have the line either go off more like that, or sometimes we might see the line kind of have a more steeper change like that. These are usually suggestive of neck of femur fractures. Moving on, we then want to check our S component. So again, if there are any changes in the soft tissue spaces or any of the joint prostheses. Again, talking about the concept of orthogonal views, we will additionally do a lateral view when we're taking these. You'll find quite often in clinical practice, it can be harder to see all the bones as clearly as we have over here. But what they will be useful for is if we can, again, trace the borders of the femur as we can over here. And again, giving us a second view from a different angle can give us a better idea of how displaced a fracture or a dislocation might be that won't have been so clear from the first x-ray. Beyond that, we have the frog's leg view to the right over here, which is usually used in the context of pediatric patients to look for hip dysplasia. Now we have our first x-ray to look at, and again, we're just going to approach these using the principles that we've gone over, so with the ABS system. And I want you to pause the video here, see if you can work out what's gone wrong with this, and we can resume after. So hopefully you've paused it and had a look at where you think you can find the abnormalities. Firstly, we're going to check the alignments with A, and again, if we've traced the spinous processes, it's roughly in line with the pubic symphysis that we can see over here. Now the next thing will be to trace the pelvic inlet, and if we start over here, we'll find that there's a step over here right where our sacrum meets our iliums. Now this over here suggests a dislocation of our sacroiliac joints bilaterally, and so that's our pathology. And again, we would go on to trace the other rings and the other bony border and so on to make sure that we don't miss anything else, because you can indeed get multiple pathologies in the same x-ray. So the key with this is to be systematic and to always go through the full process. In the interest of time, we will move on. So here's our next x-ray. Again, if you can pause it now, and we will discuss it in a moment. Right, so hopefully you've had a go at going through the system that we've described to point out what you think will be the problem. Again, looking at the alignment, that looks good to me. Tracing the pelvic inlet, we're fine there. The rings as well are fine. And tracing the borders of the pelvis is fine. When we look at the alignment of our femoral head on this side, on our right side, we can see that it has dislocated from the acetabulum. In particular, we can see that there is medial angulation of the femur, which would suggest that it is a posterior dislocation where you get external rotation of the femur and medial angulation, as we can see over here. Moving on. Again, pause the video and we'll discuss it in a second. So hopefully you've had a look and are now starting to get familiar with the system that we've been using. So now at this point I will start going towards just the main findings that you should have picked out, and hopefully when you would have traced our obturator ring on this side, you'll see that actually we have this step over here, the area appears more lucent than we would expect, for instance on this side, over here, to suggest a fracture of the superior pubic ramus. And you can also see another break inferiorly to the inferior pubic ramus, suggesting fractures of our pubic rami. Moving on. Again, pause the video and we'll talk about it in a second. So hopefully you've had a look at this. And again, our main finding over here is our intertrochanteric right femoral fracture. So an important thing to point out here, so between our two trochanters, we've got our greater trochanter over here, and we've got our lesser trochanter over here. So the intertrochanteric line is an important landmark to demarcate the borders of our joint capsule. So over here, we have an extracapsular femoral fracture. Moving on. Pause the video and see what you think. So what I want to point out in this is, perhaps it'll be quite obvious, we have quite a significant widening of our pubic symphysis. Now, what we would usually expect for this in most patients would be by the age of 20 years old, we would expect this distance to be under 6 millimeters, and by the age of 50, we would expect it to be under 3 millimeters. Over here, we have what is called pubic symphysis diastasis. So, pubic symphysis diastasis. And that is defined by our pubic symphysis distance being over in your pregnant patients. Moving on, just an example of joint prosthesis. The most common ones you will see in the pelvic x-rays will be the hip replacements, and over here we have a total hip replacement where you can see both the pelvic component and the femoral component over here. So now we're moving on from the pelvic x-rays. Generally speaking, in terms of long bone anatomy, there are a few things that are worth talking about. Over here, obviously, we have a schematic drawing of the femur. The parts of the bone that are important to point out are, firstly, the bit which articulates at the joint space. We have the proximal epiphysis. Epiphysis meaning near the physis, and the physis is our growth plate. And that's what we'll usually show in pediatric x-rays. Distal from the physis, we will have the proximal metaphysis. So the proximal metaphysis will be the area where you will get growth, and it's between the epiphysis and the diaphysis. The diaphysis is what we have over here, and this, what would otherwise be known as the shaft of the bone. And then we're back to the metaphysis, distal metaphysis, and then again we have the distal epiphysis. One thing to point out is sometimes you can have what is called an apophysis. And this is usually a non-weight bearing part of the bone, and it's effectively the bit where the part of the bone which a tendon joins onto. For instance, in the femur, we will have the greater trochanter being an important apophysis. Equally, the lesser trochanter will be too. Moving on to knee x-rays, we're going to follow a very similar approach again. So starting with A, we will look at the alignment of the image. We have two views. We have our AP view and we have our lateral view. When we're looking at the alignment of our AP views, if you draw a vertical line down from each femoral epicondyle, you should see that the distance between the femoral condyles, when we draw a line down, and our tibial, the femoral epicondyles and our tibial condyles, should be under 5 millimeters. Anything greater than this might suggest a possible tibial plateau fracture. We should also see that the joint space should be like this. We should have a nice clear joint space which runs along the whole length of the tibia. We should also see that our fibular head overlaps with our lateral tibial condyle over here. With our lateral view, we should see again our patella hovering nicely above our femur, and again we have overlap of our fibula with our tibia posteriorly now. Moving on to B for bones, trace the bony borders of all of these. So in that AP view, we can trace our patella over here. We then trace the borders of the femur at the condyles again, and the epicondyles, making sure to look for any areas of breakages, any sharp changes in the borders to suggest fractures. We're going to trace over the tibia and our medial condyles, tibial plateau, the tibial spines, again over our tibial plateau, and the lateral condyle, and following it down, and then our fibula. All areas where we might see fractures. And again, do the same on the lateral view, tracing over the borders, looking for any breakages there. Moving on, we then have the soft tissue components, so our ABS. And of course, we won't be able to see the ligaments that we're familiar with, i.e. the medial collateral and the lateral collateral, our ACL and our PCL, and so on, ACL and PCL like that. The most important area that I want to draw your attention to for the purposes of this will be your suprapatellar bursa, which sits around here, and this will be the first area to fill up with fluid. When you get bleeding into the joints, you can often see an effusion in this area or a lipohemarthrosis, which we will see later on. Looking at this x-ray, the main thing I want to point out will be the appearance of growth plates, so we can see quite clear lines over here. This will be a teenage x-ray where the bones have not completely fused yet, and these are the physes or the growth plates. We can also see a skyline view sometimes, and the most important use of this will be to look for patellar fractures. One thing to draw your attention to is how it extends further out laterally. We should see nice smooth borders like this. Because it extends out more laterally, it is more common to get fractures on the lateral aspect of the patella. Now here's our first x-ray to review. Again, I want you to use the ABS system that we've gone over. Pause the video, have a look, and then we'll review it in a moment. So hopefully you've had a chance to look at this x-ray. Again, we're going to look at the alignment. We can see that our femoral epicondyles are within 5 millimeters vertically of our tibial condyles. And now when we move on to look at the joint space, hopefully it should be clear that our joint space over here is very narrow. Our tibial spines are effectively in contact with our femur over here. So this x-ray is consistent with osteoarthritis, and the key x-ray features that you can see in osteoarthritis will be 1. Narrowing of the joint space. So narrowing of joint space. 2. We can also see osteophytes. We understand osteoarthritis to be a process of wear, tear and repair, i.e. the bones rubbing, getting worn down and repairing at the same time. And we can see our osteophytes such as over here and over here, areas where we're getting new bone growth. We can also get subchondral sclerosis, so subchondral sclerosis, which is evident in areas over here in the joint space, and we can also get subchondral cysts. Chondral cysts. Okay, and those will be clearer. For instance, if we zoom in like this, we can see areas of lucency over here and here. Moving on, one thing to point out is that we have two different x-rays here showing two slightly different things. So pause them, look at both, and we'll review it. So hopefully you'll have had a look, and we can see over here, when we look at the suprapatellar bursa, we can see a density over here, and this is the appearance of an effusion in the suprapatellar bursa. On the x-ray that we have on the right, we see quite a straight line, which the arrow has quite helpfully pointed out over here. And this is a fluid line, and this is what you would get in a lipohemarthrosis. So ultimately, when you get bleeding into the joint, often following trauma, you can see this when the x-ray is taken with the patient supine. This is important because sometimes fractures might not be as easily visible, or damages to the ligaments and so on in the area. Again, we can't see them very clearly. but this sign would suggest an injury. Moving on, we have another x-ray. So again, pause it, follow the same pattern of the ABS and see what you can find. So hopefully you'll have had a look. Again, we can see our alignment from this looks quite good. Again, just to point out, this is a pediatric x-ray, as you can see, with our growth plates over here and so on. And hopefully what you would have found when you were tracing over the borders of the tibia is this line over here. And looking at the lateral view, again, we can see a break to the borders which we wouldn't get in a normal x-ray to suggest a fracture of the tibial spines. Moving on to ankle x-rays. So over here we have two different views. So we have the mortise view and then we have the lateral view. Starting with the mortise view, we're going to look at A again. If we look at the images, we should see our tibia and our fibula. We should see a small area of overlap distally there. Any spacing between here would suggest a rupture of the syndesmosis, which joins the two of the interosseous membrane. The next thing to point out will be the joint space over here, and we should see a nice, even and consistent joint space tracing along the whole of our talus. This joint space should usually measure 4 millimeters. Any changes to this, for instance, if we get any narrowing laterally, so here we have our lateral malleolus and our medial malleolus. If we get any narrowing in our lateral portion over here, that might suggest talus shift, which you can see in an unstable ankle fracture where you have rupture of the syndesmosis. Next, you would want to trace the bony borders. The important things to point out here, so we have obviously our tibia, and again trace the whole length of it. We have our fibula. Communicating with these, we have the talus. We can see our calcaneus. Moving more distally, we've got our navicular, our cuboid, our medial, intermediate and lateral cuneiforms, and then the base and part of the metatarsals. Laterally, again, we can see the tibia. Tracing this, sometimes this area posteriorly is called the posterior malleolus. And then we've also got our fibula, and again, the talus, the calcaneus. We've got our navicular, cuboid, cuneiforms, and then the metatarsals. We can see the base of the fifth metatarsal over here. An important angle to check is what we call Bowler's angle. So, Bowler's angle. What we should see here is if we draw a line joining the most superior aspect of the posterior facet with the superiormost aspect of the anterior process, we should see that the angle formed over here should be over 25 degrees. Anything less than this would suggest a depressed fracture of the calcaneus. And then lastly, we will check over the soft tissue, any evidence of any soft tissue swellings. Moving on, we have the calcaneal view. And again, this can be used when we're suspecting a calcaneal fracture and we can't see anything as clearly in the lateral or mortise views. And again, the main thing to trace over here will be your calcaneus, which we can see over here. So moving on to our pathological fractures, these are two different x-rays to point out. I want you to pause the video and see what stands out. So hopefully you'll have checked this and you can see that when we're looking at alignment, we can see that there's our area of overlap here. When we're looking at the alignment of our joint over here, what should hopefully be clear is that once we get here to the lateral portion of this x-ray, we should see that we have a narrowing of the joint space here. Whereas if we look on the x-ray on the right, we should see that the joint space remains a lot more consistent. This suggests that we have in this x-ray a degree of talus shift laterally, suggesting an unstable fracture. We can see when we trace the bony borders that in both of these x-rays we have fractures of our tibia over here. An important classification to point out for our tibial fractures is the Weber classification, for which we have three types. We have A, B, and C, which all describe where the fracture lies in relation to the joint space. A Weber A fracture will be below the line of our joint space, so here. Weber B fracture will meet at the line of the joint space, as we see in both of these x-rays where the fracture meets the joint space there, and a Weber C will be above, so anywhere above this, if the fracture was here, for instance. The importance of this is A will be the most stable and C will be the least stable. As you can see over here, we have two cases of a Weber B. In one case we have no joint space narrowing, implying that this is more likely to be a stable Weber B fracture. And over here we do have lateral talar shift, which would suggest an unstable fracture, which you would be more keen to operate on. Moving on, again, pause the video and we will go over it in a moment. Hopefully you'll have had a look at this, and again, drawing your eyes to the most important part of this. If we again look at Bowler's angle, hopefully we can see that our angle over here is very narrow. Perhaps it will be better to draw it with some actual straight lines. So if I draw a line there and a line there, we should see that this angle is now much narrower than what we saw earlier, and this would suggest a calcaneal fracture, for which we can see over here. So moving on to foot x-rays, again we have two views, so we have our AP view and we have the oblique views. Using our ABS system again, we want to look at the alignments of all of our joint spaces. So we have our interphalangeal joints over here, and we want to make sure all of these are correctly aligned. We then have our metatarsophalangeal joints and our tarsometatarsal joints over here. Important checks to have are on our AP view. We want to see that the medial border of the base of our second metatarsal should align quite nicely with the medial border of our intermediate cuneiform. And on the oblique view, we should see the medial border of our third metatarsal base align quite nicely with the medial border of our lateral cuneiform. Looking at the bony borders again, we will trace them for all of the bones, moving through our phalanges, our metatarsals, our cuneiforms, our medial, intermediate, lateral cuneiforms, our navicular, cuboid, talus, and our calcaneus. You can also see, although the image quality isn't as good here, the tibia and the fibula come into view. And again, we will do the same on this, tracing over our phalanges over here, our metatarsals over here, the cuboid, navicular, lateral, intermediate, medial cuneiforms, our talus, and our calcaneus just coming into view. And then to look for any soft tissue swellings or anything else. Changes to the joint spaces, such as what we mentioned over here, would suggest evidence of dislocations. Of particular note will be Lisfranc injuries, where we get a fracture dislocation at the base of our metatarsals, which we will see later on. So moving on, looking at our first x-ray again, I want you to pause this, go through the system that we've used, and we'll go over it. So hopefully you'll have had a look, and again, jumping to the most pertinent findings to prevent this session getting longer than we need it to. Hopefully you'll see, once you reach the fifth metatarsal, that at the base we have a fracture here, at the apophysis of the fifth metatarsal. Moving on, pause the video again. So hopefully you'll have had a look at this, and we can see a widening of our joint space here between our first and second metatarsals. And over here we have areas of lucency to suggest a fracture. So this would be our Lisfranc injury. At the base of our third and fourth metatarsals we can see the injuries, and the widening of the joint space suggests a Lisfranc injury. Clinically, you would want to look at the patient's sole, and often bruising would be more concerning for this. If we see bruising and the changes in the joint space is not so obvious, we'd want to consider CTing this patient. Our last one for this session is this. So if you pause the video, we'll go over it in a moment. Now, hopefully when you'll have been tracing the borders of this, you might have noticed at our fourth metatarsal, we've got some lucent opacifications over here. This would be more in keeping with a stress fracture, where over time, as you've started to get repair of the fracture, you can see bone callus formation in this manner. So this is what you would see with a stress fracture. That brings us to the end of the session. Thank you very much for listening and staying with us for the duration of it. I know it's been quite long. Hopefully it will be useful, and the take-home message with all of this is to be systematic, to make sure you go through each aspect of the x-rays, most of the cases with lower limb x-rays. The bones are your main concern. Make sure you check the alignment, all the aspects we described about the different bones and their borders, and any changes or breakages to those, and any changes to the soft tissues. We'd really appreciate if you could give us some feedback on this session, and hopefully we can use this to improve future sessions that we give. Thank you very much again, and I hope you have a nice day.